Hi there, Gabe Drapos from Pearl Health, and I have with me Etosha McGee, who is Director of Consulting Services with Hospital Pricing Specialists, and Mike Kopko, CEO of Pearl Health. And we're going to just talk a bit about some questions in the hospital pricing space and the movement towards risk, particularly with Medicare's direct contracting program. And I'll say, before we dive into the questions, I was surfing Reddit a couple of weeks ago and came across an Ask Reddit thread that was sort of at the top of the chain that had a question that was, what has no reason to exist in 2021 and yet it does? And the top answer was having no idea how much you'll pay for a medical procedure. And so I think that just highlights that this is something that's top of mind, even outside of the more esoteric circles of folks like us that are really invested in healthcare. This is something that impacts people across the country. Medicare is really the foundation upon which all provider pricing in the US is indexed. It creates a shared language in that sense that, commercial rates are in 200 or 250 or 300% of Medicare. Do you think this consistency plays any role in facilitating a more efficient healthcare marketplace?
So I definitely think that baseline of Medicare payment rates certainly provides for some efficiencies in communication kind of intra-industry, right? It's a common language between providers and health plans and vendors. And that allows some ease in our communication, creating baselines, benchmarking. Many providers will use that as sort of their baseline for setting their pricing policies. And that's a good thing. But I think when we start to talk about consumers, that same value really isn't there in the consumer population. I don't necessarily think the public as a whole really understands the tight common thread that exists between Medicare's payment rates and those that we see in a managed care commercial space.
Yeah, I mean, I think, to add to that, I think Natasha has, really well pointed out, it definitely creates an index or a common language that people can discuss. But, one of the problems that I think, healthcare doesn't quite operate like a lot of markets is it actually, when you think of it, is it's set by a payer, namely in this case, the government. And there are very, rarely in markets where someone is saying this is just the price. Generally prices are either a reflection of the cost of production if you're operating in an efficient economy, or it's, the perceived demand. In this case, we basically have something that a government is saying, I am willing to buy services at a certain amount. So what I think you've seen is the private sector, namely in this case, insurance companies, negotiate with that as the index, but then negotiate their whole set of individual and specific prices with literal carve outs on services for which they're trying to, optimize margins or whatever it may be. And so that kind of begins in a little bit, Gabe, to what you began in the Reddit comment, it begins the problem that there's this occlusion of the actual price because those contracts become proprietary, though there's a big movement to kind of make them more public. But at the same token, it's very hard for the individual consumer to know what they're going to be paying for. And so, if this was a purely competitive market, I would argue you would not have government just setting a price and then, just deploying it. You would have services that are bought and sold by the payer and the consumer of it. But we're just not in that world in healthcare. So I think it's helpful by creating some sense of transparency, but it is being gamed in many ways. And I don't think you can actually get rid of that gaming in any long-term sense, because it is the business strategy of the large provider systems to basically not let you know how much they're offering that service for so that they can optimize margins with their insurance contracts and large employer contracts.
Yeah, I definitely think Mike's point, especially with the kind of divorce of cost from price in healthcare, is kind of, I think, what creates that sort of disconnect from the outset of understanding the actual cost of services for individuals within our current healthcare system.
Yeah, and the only thing I would argue and kind of add to it is that, what might be more important than a fixed price is the person that's, ultimately making the decision to consume or order a service knows the cost of it, in the same way that we're not really demanding as a society that travel is a known fixed price whenever you're going somewhere, that it's like defined and guaranteed, but that when you're making a decision to stay in a hotel or book a flight, the price at that moment. What's different about the US healthcare system is almost nobody knows the price in that moment. Not the patient, not the physician, often not even the hospital surgeon and operator. It's frankly in the sky and no one really knows. And then the bills are resolved after all services are rendered. And that kind of creates its own set of problems. But you might argue that instead of having a fixed price, you may want pricing information presented upon consumption or decision to consume services as a way to be more efficient with the selection and kind of the utilization of these services.
That feels like a great segue to my next question, which is, in 2019, there was a mandate that hospitals start posting their charge master on their websites. And at least in my experience, in large part, what that resulted in was health systems, burying a very confusing PDF file of what things might cost on the charge master. Do you think that was essentially sort of the only way that could have played out? And if so, do you see sort of similar concerns with how this is likely to materialize with the 2021 requirement of producing a machine readable file, or the 22 requirement for a good faith estimate?
So I definitely think that approach was kind of to take a graduated approach for providers to releasing this information. We're kind of going from a completely black box situation of nobody really talks about a charge master or what charges are, to where we are now in 2021 of you need to show us your actual payer negotiated rates. So I think publishing of the charge master was kind of this interim step in that, more so to socialize providers to publishing this information, less so in actually, I think, really being valuable to consumers. Charge masters contain a ton of really dense information that essentially doesn't really tell a consumer, hey, this is how much your out-of-pocket cost is really going to be for this service. Even now with the machine readable file, I think we're getting closer to being in a better place as far as, again, lifting the veil around prices and payer negotiated rates and having those conversations so that people really understand all the mechanisms at play here. But to say that downloading that file is any more useful to an everyday consumer than the CDM was, I don't think that's the case. What I do think is valuable, though, is that information is now out there for third parties to then aggregate that and pull that in and start to create tools that do give consumers the kind of information that they weren't privy to before, particularly around payer negotiated rates and starting to understand. I have, United or Blue Cross or Cigna, and this is what they are going to pay this hospital for my colonoscopy, but this other hospital down the street, this is what they're going to pay them for my colonoscopy, and start to understand that relationship between, my benefit information and what those payment rates are, and make better educated decisions. But that information definitely needs to be pulled in to some other ancillary tool in order for consumers to really do that. The idea that, my grandmother is going to go download machine readable files and shop for her services is just not the case.
Right. And probably becomes particularly relevant when at the same time you have increasingly growing deductibles, particularly amongst most commercial insured populations.
Absolutely. When you start to look at the increase in high deductible population, it becomes really critical that people are able to navigate that cost related information in a much more understandable manner.
Yeah, I mean, I'm definitely in alignment with Etosha on the progress we've made, and having more transparency is a good thing. Progress takes time, especially in healthcare, and there are a lot of interests that are, frankly, fighting against this, and understandably so. I mean, we saw a little bit of this in some of the privacy wars of social media a little while back, where people are surprised at how the actual industry operates, and as they learn more, it's actually really hard to really reclaim any kind of control and information. And you need tools and services, often by third parties, to Etosha's point, to help make things clearer. One of the other things to note that's very distinctly different is that this is a three-way relationship. You've got insurers, you've got providers, you've got patients. And so you actually have to have them all coordinating effectively for the patient to resolve well, because the patient is very rarely having any negotiation discussion with the provider. So they only do that through their insurance lens. And so I think you see more movement towards transparency. It's one, just causal, because patients are now more on the hook, and they just have to be. The $1,000 deductible plan of 10 years ago is now the $6,000 deductible plan, and people are more aware of what things cost. So I think there'll be just a natural shift toward transparency, and at least a lot of frequent services. You're going to have a problem that the industry, at least on the provider side, especially the large delivery systems, have no interest in sharing this information. And while they'll, we've seen them kind of delay their releases because the fines aren't substantive enough, it's kind of, I'll speed because the ticket's cheaper than going slower kind of mentality. It's easier for them to hide it than to pay the fines. And it's a business strategy decision. Ultimately, it's not. I mean, we can get moral about it, but it is really in their at least profit-making interest to prevent some of these information sources to become easily readable, because that'll prevent them from getting the business that they normally generate. The other thing I would just say in terms of the move towards transparency, it does require an educated consumer base. And that's why I think all these types of conversations and these companies are important in the ecosystem to help educate consumers, because if they can't process and read this, it really is not for much gain. And it is really critical to take a consumer focused lens to it, as well as having a tool for providers ultimately to help navigate consumer decision making, so that they can point you to more cost effective solutions, because they're ultimately the gateway to all of these more expensive sources of care.
At the same time, your payers do have an incentive to surface, more efficient sites of service for their beneficiaries, for their members. So Etosha, I totally agree with your point that there will likely be some third-party solutions, but I imagine payers themselves will want to make this information more readily available to their insured populations.
Yeah, and I think we see with other legislation, right, transparency and coverage that's going to require the machine readable files from the health plans, and some of what we're seeing with like the No Surprises Act, which I think speaks to Mike's comment about, this coming from a consumer focused lens, that as we focus on all of the parties in here, we've talked about providers. Hey, providers, you need to put your information out there. We've kind of given the payers their directive of, hey, you're going to have to put your information out there. And then what are also the tools that we're going to give to consumers so that they're engaged in this? And we see all those components, but to Mike's point earlier, it does take time. And that's sort of where we are, the stages of these things rolling out.
I mean, we've made a lot of progress. I would say probably 5 years ago, if you polled people, they would say hospitals will never share their charge master. We're seeing the dam is broken. They're out there. Now there's still some holdouts, but the fact that there's now these industries and businesses that are built to kind of index and share it is major progress. And I think we'll probably be in a very different space in 5 to 10 years. And when you get out of the kind of wins and losses of which companies are going to be most hurt, as a society, I would argue we're much better off helping people get to the cheapest, best care they can get to, because that enables more healthcare for the same dollars for all of us. And so I think there's going to be a generational force, but it may be also a generational timeline that it takes to finally make this a completely different world that you look back and say, I can't believe you used to not be able to see these charge masters. I think that's going to just take a while.
It's a huge shift. And now the government's saying, hey, I don't care if you are an out-of-network ED, but an in-network surgeon, et cetera. Our expectation is that patients are going to be able to come to this facility when they're in need of emergent care and have this, processed from an in-network standpoint and not be surprised with a massive bill. I think that's kind of been one of sort of the biggest kind of like glaring, when you see the articles in the newspaper and magazines, et cetera, are people going, I had no idea I was going to get a $12,000 bill. No one told me this. I had no way of knowing this in advance. Really, the government kind of coming in and tamping down on that and saying, okay, no more. And I think that's really critical, because again, that goes into all the different mechanisms we have of, are you in network? Are you out of network? Have you met your deductible? All of these layers to this system that are external of the provider, right? So I think a lot of the hits on this have been, well, this hospital sent me this massive bill, and not really understanding the responsibility at all layers of, how this interacts between hospitals and health plans, and, the benefit structure. And now how do we prevent the patient from being the one who's essentially holding the bag in this scenario, because they're the one with the least amount of resources coming to the table here.
And unfortunately, all systems are imperfect, and this is kind of one of the embarrassing imperfections of our kind of the triangular system between providers, insurer, and patient. And it actually winds up being, frankly, highly predictable at some level. And I was kind of in some of these war stories in my last role, where the incentive of the providers to bill as extremely as they can, the incentive of the insurer is to pay as little as they can, and the patient is the hostage in between. And I'm glad that we're starting to remove the ability to do it, but it's still going to keep happening because there's just a lot of gaming to be involved. And I've seen $1.4 million appendix removal case where Medicare would pay $7,000. I've seen, air transports for $250,000, a third the price of the airplane that someone was, flown from New York to Texas in. I mean, some very extreme situations that, the patient is rightfully at a complete loss. And frankly, you'd argue it's almost like violence of a century ago. It's just modern violence where you're putting someone's basically house and entire, balance sheet, often well more than that, on the line in these transactions. And it's a very painful experience. And I can just tell you, I mean, without sunlight and without, the press getting involved or laws, you basically do see people playing this game of chicken where, the incentive of the provider and the insurer is to not agree and use the patient in the middle as a device to kind of advocate for their economics. And I'm glad to see that it's starting to at least get easier. And there's a lot of great journalistic sources that capture these cases and bring them to light. Those are often, believe it or not, the fastest ways that I've seen them get resolved is because someone writes an article and puts both names of insurer and provider in the press, and they both realize it's time to end the nonsense. But I think this will keep happening. I think you'll see other games around assisting surgeons, novel technologies. The problem is when something isn't priced and there is some assumption that it will be paid for, then there becomes a debate of the service was already rendered, the price was not set, what shall be paid? And I think we're going to see more and more of these kind of repeated games. And it really does just mean you have to have a big system behind you. It's the only real way to fight that, and the patient often, unless there's a really great patient advocacy group that they can be represented by, or they're willing to go to the press, winds up being kind of the weakest part of that negotiation. And it's a really sad thing to see. And I'm really excited to see us kind of as a society tear it down, because frankly, there's not even a lot of money involved. It is the territory of unagreed rates and services. And so it's really just a contracting gap, but it is basically litigated through an unknowing patient.
And I think, also when you start to look at like the good faith estimate requirement, the advanced explanation of benefits requirement, starting to make both providers and health plans put a lot of this down on paper before people are receiving services are going to be really crucial in starting to eliminate some of what we're seeing here, these gaps or these, sort of games that get played. While HHS is still doing some rulemaking around that, so there's going to be some time before we see what this actually looks like in practice for consumers. I think it is so important that we're at least starting to see legislation around something has been scheduled. You have 3 business days to tell someone what it is going to cost them. What services are they receiving? What is it going to cost them? A big gap right now we see is, well, hospitals will say, I can give you an estimate for what I'm going to bill you for, but I don't know about this external surgeon, or I don't know about this external anesthesiologist. And so now with the good faith estimate requirement, right, that's applicable to not only a facility, but all the providers. So now you're getting that kind of more comprehensive view of, this is what the hospital is going to bill you for. This is what the surgeon's going to bill you for. And me as your health plan, this is what I anticipate paying them. And this is going to be your responsibility. And I think sort of, again, lifting that veil and getting further up in the life cycle. So much of what we do right now in healthcare, particularly around reimbursement, is, well, after the services were rendered is when we then try to like have a conversation about it or go back and forth about it, or actually tell a patient what their cost is going to be for something. And we've got to move that much, much further up so that people are no longer kind of, again, ending up with these surprise bills or these financial expectations that they were not prepared for.
Yeah, and to really, it's going to require an educated consumer base. I'll say it again, just because those notices are going to be complex. And I've seen the other side of a lot of these kind of required notices, and it winds up being very hard to parse from a consumer perspective. And, there's a real challenge in just thinking about how many businesses and their industries have been built in kind of playing these games. If you look at, and I'm not going to pick on anybody in the sense of, everyone's trying to participate in the healthcare system and pay their bills, but a lot of these kind of hospital-based physician groups strategically have left themselves out of network because that is how they, get their highest fees. And so you have to really kind of solve the problem holistically, because they're not going to necessarily play nice unless it is a legislative-based change or their economic opportunity changes such that cooperation is more rewarded than, frankly, anti-cooperation. And there are these like little like kind of fraying seams in the healthcare system where you see this coming apart. And it's really important to either think, are you going to solve it from a legislative perspective? Can you solve it through contracting like insurance plans, et cetera? But ultimately, it'll be the consumer that pays the price where those seams are fraying, because they're the ones that have a reasonable expectation that things have been resolved. And often, for the sake of purely business purposes, they have been left unresolved. And so, anyway, I think we're going to keep making progress. I'm generally optimistic. We've gotten a lot more education on the consumer base, but we're still going to see some crazy stories as we kind of test these seams and their tightness.
Oh, absolutely. And I'll say the one thing that I think at least is also good in this current environment is the release of the machine readable files allows for that third party who's not incentivized in the same way as a provider or a health plan to also engage with this data. And I think that can also help as far as, better consumer education and better availability for this information for consumers from an entity, again, that's not incentivized in the same way that health plans or providers are.
And the charge master thing, I think, is also fascinating. I'm waiting for like the set of articles that come out, because a charge master technically allows you to bill. I think there's actually no limitation to what you can bill. So I can provide a service to you at 12,000. I mean, this 30-minute interview, I'm billing you for $50,000, right? Because that's just the charge master. Now, my negotiated rate is $800 or whatever it may be, right? But the minute you come into my facility and you have my time that I didn't agree to out of the gate, I'm hitting you with that charge master. Now, the interesting thing becomes who is defending that rate? It would be a court of law or federal government that would have to honor that. And so there is a world that as consumers become more knowledgeable to say an appendix removal under no circumstance will ever be $1 million. And it's frankly ridiculous to request that we'll see that start to get curbed. And then it will be either on, an electorate that says we're going to either come in and regulate this, or it'll be on frankly, a market shift where you have maybe providers who are more involved in risk. And I don't want to bill $1 million for that service because then I don't make any money on the next 100 customers that I serve. And so you have to either change the incentives, I would argue, or you got to change the rules. Typically, private sector actors, especially when they're well financed, are faster than the rule changes. Is my bias or my kind of orientation. And I think you really got to make sure you understand what the incentives are creating out of the gate. And that's one of the things that surprise billing to me is just like a classic case of law of unintended consequences, where you can really bill what you want, and because it's uncontracted for, there's a long tail of a dispute that has to take place.
And I'd like to close out sort of shifting a little bit to a topic that is near and dear, at least to Mike and I, and that is the growing movement of providers to taking on risk directly for the total cost of care of their patient panels. That's really clear cut when you're talking about an independent PCP. If you're lowering the total cost of care, the downstream costs of, let's say, hospital visits, emergency room visits, specialist utilization, et cetera, to create more efficient care and in more efficient sites of service, that's clear math. Lower costs results in more savings that goes to the primary care provider. It gets a little bit more complicated when you're talking about a hospital system where they are employing the providers, they own the facilities and services that are being provided across that healthcare delivery chain, representing much greater percentage of the total cost of care. How do you think those health systems should think about sort of moving into this next stage of value-based care?
So I think the moment we're in right now is honestly, unfortunately, is kind of a stark indicator of why thinking differently about our models is important. This sort of volume utilization driven model has come to a grinding halt, right? Like our EDs are full because of COVID. There's no inpatient beds. Elective and non-emergent procedures are now having to be stopped. And so I don't think health systems have sort of a really good model in place of like, how do you course correct in this sort of environment? And so I think thinking about looking at total cost of care and how you leverage the fact that you have built this system with a wide spectrum of practitioners to support inpatient care can actually be leveraged for better outcomes, better utilization of hospital and provider resources, and really and truly become a better overall model. So that may mean that, yeah, you're going to see a dip in your ED volumes because you're keeping patients from reaching that crisis level, or a dip in your cath lab because people don't necessarily need an interventional procedure because you've been able to kind of curve that trajectory for that person that was on that path. But that also means that you are, better utilizing your registered dietitians, your PharmDs, and all the different types of practitioners that are present within the health system. I'll also say what we've, kind of seen with Medicare particularly, and it kind of goes back to our very first question about Medicare payments being the baseline, is, where Medicare goes is typically where the rest of the industry tends to follow. And so when we talk about overall cost containment and, really tamping down on the just exorbitant growth of cost of healthcare in this country, seeing successful Medicare direct contracting models are kind of the framework, the foundation for how we then can take this even further and apply it to wider populations that health systems serve.
Yeah, that phrase "where Medicare goes, where healthcare goes" is actually one of our internal refrains. So we're highly aligned there. I think anybody who would be first introduced to our healthcare system, if you described that most of the expenditures were premised on services rendered by the provider, they'd kind of scratch their head a little bit. And I think our system in general is exposed to too much of that versus a more diverse model that you'd be looking at managing a total cost of care. And I think one of the big shifts, when we look at how risk is managed in healthcare in our country, it's kind of more like this old big box strategy. Like the bigger you are, the more risk you can manage, and you can use all that leverage, mostly as a health plan. They also pass it on to our taxpayers, and they kind of use that leverage to kind of defray the risk on. I think as technology, capital markets, and frankly, our healthcare innovation have evolved, I think you're going to see a lot more players who are interested in taking on risk. And risk historically been a four-letter word. The Society of Actuaries, which is generally a conservative group, has changed their slogan to "risk is opportunity." And I think there is a world where you'll see clinical specialist providers start seeing themselves almost as quasi health plans, where they will take on the exposure of the total cost of care because they have the most agency or ability to control it. And I think that's a really healthy dynamic. I think otherwise you're basically looking at a world where health plans manage it all, and you have people who are just focused on generating services for a margin. And I think we're interested in not only direct contracting in this kind of major shift in Medicare, but also kind of as a preview to where healthcare markets may be going, and particularly clinical innovators who, instead of saying, well, how do I get to the CPT code that I can then produce a lot of, they'll say, well, I think I can impact the total cost of care, and I'd like to have exposure to that because I'm most aligned and my clinical model is most aligned in that world. And so we're really interested, at least at Pearl, at helping not only facilitate that, but also to kind of start democratizing the access to healthcare risk and changing it from a four-letter word to an opportunity for providers and other groups who help manage patient experiences and patient costs, because they're often the best position to influence and, frankly, control expenditures.
I would just say, one other thing, as we've talked a lot about, bringing patients into this process more as well. I think when you approach healthcare from that perspective, you get better engagement from your patient population, which then also results in better outcomes. And ultimately, right, that's what we really want to see, a healthier population. We want that people, don't need to be in EDs, don't need to be in cath labs or et cetera, right? Like that's the ultimate goal, is to be able to better manage that population. And I think in that model, you are also going to get better engagement from your patient population.
I mean, I think a lot of this is also just some of the elements that make us human, that giving people attention and empathy in their kind of caring and healing process is a big thing. And you see that over and over again with the high levels of trust for physicians with patients and specialists, and frankly, not with hospitals and other expensive, typically courses of care. But that's also, unfortunately, in our system where most of the attention is given. So there's this kind of weird incentive where the kind of higher up on the chronic and intensity scale you go, the more attention you're likely to get, because that's where the fees and the expenditures are generated. But really what I think patients need, or at least what can influence courses of care most, are kind of primary care physicians and other associate physicians who understand what's going on, can really recommend good treatments at that moment of need, as opposed to kind of a system that really is designed to treat the sick because that's when the money is spent. And I think that's kind of, we're getting a little bit of what we deserve until we change it, because that's just the economics of the business. And so what we're really interested in this shift in risk is changing that underlying, tectonic plate that says the provider can actually play a larger role. And they're not just then saying, well, I got my billable unit, I'm passing you on to somebody else who is going to be thinking in that same way. They can actually holistically treat you in your kind of case and start broadening their kind of their top of license performance, where they're thinking holistically about what's going on with their panels and their patients in those moments.
Thank you both so much for this discussion. That was incredibly informative and thought-provoking, and have a great day.